Okay, Stella, come through. Hey, there's my girl. Good afternoon, everyone. It is 3 o'clock in Nigeria, and I'm sure 4 o'clock in South Africa. And you're welcome to the 2025 World Thyroid Day webinar presentation, which is on thyroid diseases and artificial intelligence. And you're welcome to this platform, which is the Endocrine Metabolism Society of Nigeria. And today we have some esteemed guest speakers in our midst who will be talking to us on various topics, right from iodine, the state of iodine in Africa, to subthyroid, subacute, subclinical hypothyroidism, then to thyroid advocacy. But just to share with us the program that we have for today. Let me just quickly share that. The programs that we have for today. And to help and to give us a few housekeeping rules. We want to encourage and enjoy every one of us to mute our mics when we're not speaking to minimize background noise. And if possible, we can make use of headphones. Then if you have questions, kindly use the chat box to make questions or comment during the webinar. And for those who may not have opportunity to be on this platform, when the Zoom platform is filled up, we encourage you to join our YouTube channel. The link is going to be shared on our various platforms. Then we also want to encourage all these participants to be respectful and consider others within the chat box. Then, as much as possible, try and follow the instructions from the presenters and the webinar host. And let us be patient and courteous to one another. And just to mention that this program is being recorded and all participants are notified based on this. So thank you so much. As I mentioned the other time, we have a list of, we have some esteemed guest speakers in our midst who is going to do justice to these topics that we have today. So before then, I want to call on the president of the society, President Andrew Iloko, to give us his opening remark.
Hi, good afternoon from Nigeria, good evening from South Africa, from other parts of the world. I don't know if I am audible. Dr. Nopade, can you hear me loud and clear?
There's some glitches. Fine.
How are you doing now? Is my body better? I try to use the handheld. I don't know if my video is showing. Can you see my picture?
I can see your picture. I can see your video. Well, to me, I can hear you not too clearly.
Okay, I'll try to improve my voice quality. So, distinguished ladies and gentlemen, colleagues from across the world, it's my pleasure to welcome us to the World Thyroid Day activity as hosted by the Endocrine and Metabolism Society of Nigeria. We are doing this in conjunction with the Thyroid Awareness and Support Initiative, as will be let to know in the course of this program. The Endocrine and Metabolism Society of Nigeria represents the umbrella body of endocrinologists, people in the field of metabolism, and this cut across various subspecialties: nutritionists, laboratory scientists, basic scientists, clinical endocrinologists, pediatric endocrinologists, pharmacists, nurses. We are all in Endocrine and Metabolism Society of Nigeria. On a day like this, we try to create awareness as much as we can on thyroid diseases and see how well we are doing. And we have the honor of working together with the Thyroid Awareness and Support Initiative. The lady here, I got her Roma is going to be part of the speakers and the faculty. We also have eminent scholars like Aisha. I call her Aisha, but she's a Spanish already, joining all the way from Ghana. Thank everyone and Aisha for creating time to accept to be one of our speakers at this auspicious event. And across the world today, thyroid disease is discussed in World Thyroid Day. And this is going to cover a full week. I think lasting up to the end of 1 week. And we're going to see how much of thyroid illnesses we get in our practice. I don't we talk about endocrinology. I think how quickly is diabetes. But thyroid illnesses are becoming very important. We cannot not talk about it, not to create awareness of. That's why environment metabolism society in Nigeria tries to put this together, bringing the benefits to weigh on the topics that we discuss. They are quite exciting, and I implore all of us to pay that attention and to make as participate as possible. I will not conclude my brief remark. Still, I have appreciated Professor Ifedayo, who is also on the speaker faculty on the college staff. He's done great jobs in the area of thyroid illnesses and will be tapping from his wealth of knowledge. The past president of the Endocrine and Metabolism Society of Nigeria, who is also a board member of the International Society of Endocrinologists, Professor Olufemi Fasmade, will be chairing this meeting this evening. And I know Professor Olufemi Fasmade is a man of several caps. Today is his birthday. He's joining me to wish him a very happy birthday. I think it's the first major assignment on his birthday. We are honored to have him on this correct affairs of this meeting. One again, I know I may not have much time to talk, but I know Alicia. Yes, I met her sometimes late last year in a meeting. I was fascinated by her depth of knowledge in thyroid illnesses across Africa. I see a lot of collaboration with us, and she's open to such partnerships. We are already in talks, and I want it at the end of this meeting. We are going to take from that, and then we will invite the house as to what we are going to be together. There is a lot to do. All hands must be on deck to reduce the burden of thyroid illness in Africa. So it is my pleasure on behalf of the leadership of EMSON to welcome you to this. Thank you and fantastic.
Thank you, Professor Andrew Iloko, for the opening remark. So right away, I'll be calling on Professor Olufemi Fasumade, who is the chairman for this particular webinar. And today happens to be his birthday. I want to wish him happy birthday. So thank you, Professor Olufemi Fasumade.
Thank you very, very much, Dr. Rotimi Olopade. And I want to thank the leadership of the Endocrine and Metabolism Society of Nigeria, ably led by Professor Andrew Uloko. I also want to thank other partners that have joined us today, like Mrs. Iroma Ofotube, the chairman of Thyroid Awareness Initiative, and all other members that are on the call, including officials of other executive members of EMSON, other members of ICE, and then also our guest speaker, who is also going to be talking to us from far away outside the country, and all other people who are on the call. So today is my birthday. Today is also the birthday of the World Thyroid Day. So it seems as if when I was born, I had been ordained to play a role in endocrinology and metabolism, because every day, every year, I share my birthday with the thyroid people. So it means I'm a child of thyroid myself. And it's very interesting because thyroid diseases are the second or the third commonest endocrine disorder worldwide. And more than 1 in 10 people are afflicted with various thyroid problems, ranging from goiters to functional abnormalities. So the World Thyroid Day is a day that has been set aside to provide awareness on thyroid health issues. And every year it is celebrated on 25th of May. And the focus this year is on early detection and early treatment. The best way to prevent a condition is actually to look for it before it starts, because that is the cheapest way and the best way to prevent a condition. Thyroid disorders are very, very, very common. And even I that I'm speaking, I have several nodules in my thyroid gland, which I never would have known existed if I didn't go for screening. So this is another opportunity to ask people or to remind colleagues, both medical colleagues and then also those who are in the NGOs and those who are in the support groups, such as the TASI and several other groups. In Nigeria, we have about 2 or 3 thyroid support groups, and the leader of one of them is with us today. And it is important and imperative that we raise our voice concerning the prevalence, the incidence, and so that people can know what the thyroid is all about and how diseases affecting the thyroid also appear. And the only way that we can do this is through early detection. And this detection can take place even in children, in young children. There are some countries where children, for instance, do have a TSH test just to be sure that we avoid neonatal hypothyroidism and prevent mental issues, mental health issues, or retardation arising from congenital hypothyroidism. So that is how important it is. In adulthood, it is virtually impossible to go for a comprehensive health check panel without having your thyroid hormones checked. But we believe that we need to do more than this. We need to raise the awareness concerning thyroid disorders, because when you look at thyroid disorders among many other medical conditions, the person on the street, the average person on the street, doesn't even know what the thyroid is, not to talk about whether it is the object or whether it is the area that can have issues. So it is important for us through this World Thyroid Day to raise the alarm, to let people know that it is good to go and have your thyroid checked. And there are the biochemical tests and there are the imaging tests. Whichever one is done can help to detect thyroid early. Because where this diagnosis is not made early, thyroid disorders have great implications for health in the area of child health, in the area of reproductive health, in the area of dyslipidemia, cardiovascular conditions, in the area of growth and development, and several other conditions where the thyroid gland regulates or where disorders of the thyroid gland lead to disorders in. So it is my pleasure, and I'm glad to be on this panel with very many eminent people amongst who are talking, including Professor Alicia Wade and several other people that are on the platform. And we will say that please tighten your seatbelts, get ready to listen to all the things that the esteemed professor will be sharing with us today. And I'm sure that at the end of today, there'll be more awareness as to thyroid health and how to prevent thyroid disorders and how to early detect and manage them. So with that, I thank everybody who has logged on. Keep your eyes peeled, keep your ears clear, put on your seatbelts as we wait for the keynote speaker to present her paper on the thyroid. But I'm sure that before that, we'll have somebody that will be sharing her citation. So thank you, everybody. God bless you.
Thank you, sir, Professor Olufemi Fasumade, and happy birthday once again, sir. So quickly, I'll be taking the short citation of Professor Alicia Wade. Professor Alicia Wade is the Director of Research in Metabolism and Endocrinology at the University of Witwatersrand in Johannesburg, South Africa, and a reader and a clinical scientist in the Department of Internal Medicine in the School of Clinical Medicine at the same university, as well as an adjunct associate professor of the Division of Endocrinology, Diabetes and Metabolism at the University of Pennsylvania. She's a native of Barbados. She graduated from the University of West Indies in 2000 as the clinical gold medalist and with a MBBS honors degree prior to attending the University of Oxford as a Commonwealth Caribbean Rhodes Scholar and graduating with a Doctor of Philosophy degree in clinical medicine. She then completed a residency program in internal medicine at the Johns Hopkins Bayview Medical Center and a fellowship in endocrinology, diabetes, and metabolism at the University of Pennsylvania, both in the United States. She was awarded an Emerging Global Leader Career Development Award from the Fogge International Center of the National Institute of Health, United States, and she has published over 85 peer-reviewed articles. Her research focuses on health inequities in endocrinology and metabolic diseases. She is an active clinician and sees patients with endocrine diseases at the Wisdonald Gordon Medical Center in Johannesburg. Let us, I want to welcome Professor Alicia to this platform as she takes a lecture on iodine and thyroid diseases in Africa. Are we there yet? So welcome, Professor Nicole Alicia.
Thank you so much for that fulsome introduction. I'd also like to thank the organizers for the invitation to present today. And Andrew, I share your sentiments. I'm looking forward to thinking about how we can advance research on thyroid disorders and, in fact, endocrinology more generally on the continent. And of course, it would be remiss of me not to wish Professor Fasamande a very happy birthday. So I'd like to share my screen. Okay. Great. And I trust that you can all see that. Okay,
Yes,
wonderful.
please.
So, wonderful. So as Dr. Oladapo said, my presentation today is on endocrine and thyroid disorders in Africa, and really to consider, are we doing well? I think in order to frame this discussion, it's important for us to understand why some populations are more susceptible to iodine deficiency than others. And really what that depends on is how much iodine we have in the ground and in the groundwater. Now, most of the iodine that we have in the ground comes from seawater. There is a small contribution from volcanic ash, but most of the iodine comes from seawater. That seawater is aerosolized and then falls in the form of rain and then penetrates into the water table. Plants take up that water, animals will eat the plants or otherwise drink the water. And then it's through ingestion of those plants and animals that we generally get iodine into our systems. So in countries in which there is very low iodine in the groundwater, the population is then susceptible to becoming iodine deficient. So in the last 40 to 50 years, there's really been a global understanding. I think there was certainly a lot of understanding and efforts in high-income countries probably before that, but really the global efforts to include those of us in lower middle-income countries have come in the last 40 years or so, with the recognition that because so many of us are susceptible to iodine deficiency, that fortification of food is probably the best way to deal with this situation. And because salt is so ubiquitous in our diets, salt has become the favored vehicle for iodization and increasing dietary iodine. And currently in Africa, 47 countries have either mandatory or voluntary fortification of salt with iodine. But it is really important to understand that these regulations really govern table salt or salt that's used in cooking. They don't cover commercial salt in many cases, which is what's used in processed food, which is how a lot of people get a lot of the salt in their diet. And it doesn't necessarily cover agricultural salt. And the reason why this is important is agricultural salt is often cheaper than table salt. And in many lower income households, agricultural salt is what's used for cooking. Now, obviously, although iodine deficiency has been a major problem in the subcontinent, we also have to give a thought to the other side of the coin, and that's iodine excess. And you'll recall that I mentioned that what influences iodine status in a population is the amount of iodine in the groundwater. And there are places which conversely have a lot of high iodine in the groundwater. And these are places that tend to be coastal plains, islands like the one that I come from, paleo ocean environments or island basins. And in Africa, we have countries such as Algeria, Somalia, Kenya, and Tanzania, which actually have high iodine content in the groundwater. And in those countries, the populations are actually at risk of iodine excess. So besides the more common causes, there are also other things that contribute to iodine in African countries, though these probably take a backseat to the ones that I've mentioned already. So we've got our dietary sources, so seafood and dairy in particular. In some cases, iodinated contrast media in radiology studies, and then iodine-containing medications and supplements are also available and used in some places. Now, just because there's legislation that says that salt has to contain a certain concentration of iodine doesn't necessarily translate to the amount of iodine that's being used in households, partially because of the reasons that I mentioned. And in this study, they actually looked at the non-iodized salt consumption in women of reproductive age in sub-Saharan Africa. And they looked at 11 countries which were involved in the demographic health surveys. And what they demonstrated that in 5 of those 11 countries, more than 10% of the salt that was being used was actually non-iodized. And in fact, in Senegal, nearly 30% of the salt that was being used in this population was non-iodized. And in Tanzania, over 20% of the salt was non-iodized. So that just emphasizes that even though the regulations are in place, we can't become complacent and assume that those regulations are actually translating to what's happening on the ground. So how much iodine should we be getting in? So the World Health Organization and the Iodine Global Network have defined recommended intakes of iodine, and those differ depending on the age. So in the younger folk, so children aged 0 to 5, there's usually a recommendation of 90 micrograms per day. In school-age children, who they define as being between 6 and 12 years, the recommended intake is 120 micrograms per day. And in those who are more than 12 years old, so adults and older children, the recommendation is 150 micrograms. And in pregnant and lactating women, particularly because of the effects of iodine on the developing fetus and the neonate, the recommendation is for a higher amount of iodine, 250 micrograms per day. In 2004, the WHO also defined a tolerable upper level of iodine. You'll remember I said there can be issues with iodine excess as well. And that too depends on age. So in those who are between 0 and 5, it varies between 50 and 150 micrograms per kilogram per day. 6 to 12, we recommend 50 micrograms per kilogram per day. Over 12, 30 micrograms per kilogram per day. And again, in pregnant and lactating women, slightly different, 40 micrograms per kilogram per day. And having implemented these recommendations or made these recommendations, it's also important to continue active surveillance to ensure that the population is in fact getting sufficient iodine. And there are numerous ways for us to assess a population's iodine status. Probably the most common method is urinary iodine concentration. And this is based on the principle that more than 90% of the iodine that we ingest is usually excreted by the kidney within 24 to 48 hours. So that makes this a particularly useful biomarker for determining recent iodine ingestion. It's been validated as a biomarker of population iodine status, but it's actually quite poor when you're trying to assess an individual's iodine status. And that's because the amount of iodine one takes within a day or between days varies quite a lot, which makes it quite an unreliable biomarker for that purpose. Another potential biomarker, and one that is used, is the thyroglobulin concentration. And as I'll talk about a little bit later, thyroglobulin is a glycoprotein precursor in thyroid hormone synthesis, and it reflects iodine nutrition over months to years. So unlike the urinary iodine concentration, it gives us a much longer time span over which to consider the sufficiency of iodine nutrition. Its relationship with iodine intake is U-shaped, and it also can be measured in dried blood spots, which may make it a little bit easier, for example, to collect from younger children from whom it might be difficult to get a urine sample, but there is some methodologic variability in the assays. We consider thyroglobulin between 4 to 40 micrograms per liter as indicative of iodine sufficiency, again in school-age children, which is a very popular sentinel population. We can also look at neonatal thyroid stimulating hormone to get an idea of what a population's iodine status is. This is because that iodine sufficiency in the pregnant woman leads to increased thyroidal iodine turnover in the developing fetus, which then results in TSH hypersecretion. Therefore, if you measure the TSH between 3 to 4 days after birth, it can tell us something about the population in general. And we consider that if the prevalence of TSH values more than 5 is less than 3, then the population at large is iodine sufficient. Whereas if the prevalence of TSH values more than 5 is greater than or equal to 3%, then there's probably moderate to severe iodine deficiency in the underlying population. Now, the problem with using neonatal TSH is that there are no thresholds for mild iodine deficiency, and neither are there thresholds for iodine excess. And this is really used as an adjunct to median urinary iodine concentrations and thyroglobulin rather than being used on its own. Another way to determine the population iodine status is to look at the thyroid volume. And we look at, you would have heard Prof. Asamande speak about goiter a little bit earlier. And where the goiter prevalence is less than 5%, the population is thought to be iodine sufficient. 5 to 20% thought to have mild deficiency, 20 to 30 moderate deficiency, and more than 30 severe deficiency. And I hasten to say this is thyroid volume in school-age children. So school-age children, and to a lesser extent, women in the reproductive age group, are what we consider sentinel populations for iodine deficiency. And they're the populations in whom most of these studies have been done, and they are considered to be reflective of the population at large. Now, the challenge with using thyroid volume or the prevalence of goiter is that not only does iodine deficiency cause goiter, iodine excess can do so as well. And particularly if the iodine deficiency is mild, the best way to assess the thyroid is by ultrasound as opposed to palpation. But we all know how difficult that can be to access in certain areas of sub-Saharan Africa, which makes it a far less practical way of assessing thyroid volume. So having assessed the population iodine status, what really should we be aiming for? And what does the WHO consider to be adequate, insufficient, or excessive? So they use the median urinary iodine concentration, again in school-age children as our sentinel population, to really assess whether or not a population is deriving adequate iodine. So they classify it into 4 ways. There's insufficient intake, which is then further subdivided into severe, moderate, or mild deficiency. There's adequate intake, which reflects adequate iodine nutrition, and that's classified if the median urinary iodine concentration is between 100 and 200 micrograms per liter. If the iodine concentration is between 200 and 300, intake is considered to be above requirements. But there's really not considered to be a risk of adverse health conditions until the iodine intake is considered to be excessive, and that's more than 300 micrograms per liter. So what's our population iodine status here on the continent? So this graphic illustrates the estimated iodine nutrition in the WHO member states in Africa last year. And it's based on national median urinary iodine concentration from epidemiologic studies between 2008 and 2023. And what you'll see here in this graphic is 26 countries on the continent were thought to be iodine sufficient or adequate, 4 were thought to have excess iodine, and 5 were thought to have insufficient iodine. Perhaps to me, what's one of the most alarming things about the graphic is that we didn't have data in 20 countries, which is nearly half of the countries on the continent. And I also hasten to add that even in those countries in which we do have data, those data are actually quite outdated, and many of those data are not within the last 5 years. Also important to note, as I mentioned, is that most of these studies are done in these so-called sentinel populations, and therefore they don't necessarily reflect the iodine status in the vulnerable populations or in the population at large. And that's highlighted quite nicely by this paper, which looked at iodine deficiency in adolescent and young adult populations. And what you'll see here is that the 10 countries worldwide which have the highest incidence of iodine deficiency, of those 10 countries, 9 of them are in sub-Saharan Africa. In fact, Somalia, which is considered iodine deficient, actually had the highest incidence rate of iodine deficiency in 2019 in adolescent and young populations, which just highlights once more the inadequacies or the caution or the limits really we have to use when interpreting samples taken from sentinel populations. So why do we get concerned about the thyroid? I think I probably don't need to have, about iodine rather, tell this audience. It's because of its critical role in the health of the thyroid. So just a little physiology as a reminder, iodine enters the thyroid cell through the sodium iodide symporter, and then enters, crosses the apical membrane, enters the follicular lumen of the thyroid cell, and then the tyrosine residues on the thyroglobulin protein are then organofied to form DIT and MIT. And then these DIT and MIT are coupled, which ends up with the formation of thyroxine and triiodothyronine, both of which are bound to thyroglobulin. That iodinated thyroglobulin then re-enters comes out of the lumen into the cell and undergoes proteolysis or is broken down, which then results in release of T4 or T3, i.e. our thyroid hormones, into the circulation. So when this process breaks down and when we don't have sufficient iodine, we can get a spectrum of iodine deficiency disorders. Now, regardless of one's age, one can develop a goiter, hypothyroidism, or increased susceptibility to nuclear radiation. Whereas in the fetus, there's particular susceptibility, and that may result in spontaneous abortion, stillbirth, congenital anomalies, or perinatal mortality. In the neonate, so the newborn child, congenital hypothyroidism, either with or without a goiter, can result, formerly known or in some circles still known as cretinism, and there's also increased risk of infant mortality. The growing child or adolescent may be more susceptible to impaired mental function, delayed physical development, or hyperthyroidism. And similarly, adults can also be more at risk for impaired mental function or hyperthyroidism. So how does this happen? What happens in the thyroid when there's not enough iodine? So when the iodine intake falls below 100 micrograms, the pituitary secretes more TSH. And what that does is result in an increased breakdown of the iodinated thyroglobulin, which then results in increased secretion of T3 and T4. It also increases clearance of inorganic iodine and decreases renal iodine clearance, all of which really are geared at making sure there's enough iodine or more iodine available for thyroid hormone synthesis. Now, as long as the iodine intake is above 50 micrograms per day, usually the absolute thyroidal iodine uptake and content remain adequate. But what happens when it falls below 50 micrograms a day? Then there's a decrease in the uptake of iodine into the thyroid. There's a decrease in thyroid iodine content and concomitant decrease in T3 and T4, increase in TSH production, and a goiter develops. Now, iodine deficiency can have variable effects on thyroid function, even where it's endemic. So as I just mentioned, if it's chronic and moderate to severe, you get hypothyroidism, increased TSH, and development of the goiter. And when goiters are particularly large, the configuration of that thyroglobulin is abnormal. And then thyroid hormone synthesis is even less efficient, which really compounds the problem. In the initial stages, you can get your goiters are usually diffuse and homogeneous, so quite similar, but then eventually they can become nodular. And even mild to moderate iodine deficiency can eventually lead to hyperthyroidism, and we'll talk about that in a little while. It's important for us to remember, particularly in our environment, the role of goitrogens in iodine deficiency and its relationship with thyroid function. Now, goitrogens are compounds that interfere with thyroid metabolism. But importantly, the clinical effect is really only seen if they occur in the setting of comorbid iodine deficiency. So the cruciferous vegetables like broccoli and cauliflower have glucinolate metabolites. And thiocyanates, which are found in cassava and sorghum, so staples in many parts of the continent, both interfere with the sodium iodide symporter. So they compete with iodine for the uptake. So in instances in which there is iodine deficiency or concomitant iodine deficiency, then they could outcompete essentially the iodide, and iodide does not get taken up adequately into the thyroid cell. Flavonoids, so those are contained in soy and millet, again, millet particularly very commonly eaten in parts of the continent, interfere with the thyroperoxidase enzyme. Therefore, you don't have the organification, you don't have coupling all of which then lead to hypothyroidism or decrease in the production of your circulating thyroid hormone, increased TSH secretion, and formation of goiter. And these can also be exacerbated by micronutrient deficiencies such as selenium, iron, and vitamin A. So what are the clinical manifestations of iodine deficiency disorders and thyroid disease in Africa? So probably most commonly, and the one that is most frequently reported on, is goiter prevalence. And again, in our sentinel population of school-age children. And we'll see that despite the progress we've made in terms of legislation for iodization of salt, we still have quite a significant problem with goiter prevalence. So two studies, one which was done in Sudan in the south, and then another which was actually a pooled estimate and a meta-analysis in Ethiopia between 2000 and 2018, revealed a goiter prevalence of over 40%. And another study from Guinea-Bissau, actually what I thought incredibly alarming goiter prevalence of nearly 75%. Now, some of the functional manifestations of iodine deficiency are difficult to attribute solely to iodine deficiency, simply because they can have so many other etiologies. So the epidemiology of determining what functional disorders are due to iodine deficiency can be quite challenging. But I was quite intrigued by this, what I call a natural experiment from Niala in Sudan, where they supplemented iodine and then saw a decrease in the prevalence of hypothyroidism from 64% to 0.6%. So that certainly suggests that a significant amount of the hypothyroidism in that environment was due to iodine deficiency. So we've spoken about iodine deficiency and hypothyroidism, but what about iodine deficiency and hyperthyroidism? And this in some ways can seem a little bit counterintuitive. But what does happen is that because of that chronic TSH hypersecretion, you get a heterogeneous multifocal polyclonal abnormality in the thyroid, and you get the formation of nodules. Now, some of these nodules may actually be monoclonal, and some of them may be functional and have activating mutations of the TSH receptor. And then in these instances, hyperthyroidism can develop due to one of two reasons. One, it may be spontaneous, or two, in situations in which people move from areas of low iodine intake to high iodine intake, or there's introduction, for example, of iodine fortification, that sudden increase in iodine intake can itself lead to hyperthyroidism. So what about iodine excess and thyroid disorders? And once more, iodine excess can lead to one of two things. It can cause an iodine-induced hyperthyroidism, or it can have an iodine-induced hypothyroidism. And to understand iodine-induced hypothyroidism, we need to understand what's called the Wolff-Chaikoff effect. What happens there is that when the thyrocyte finds itself in an environment of increased iodine, which then enters the thyroid cell through this importer, various compounds such as iodolipid and iodolactone are formed. And these compounds have an inhibitory effect on the thyroperoxidase enzyme. And through that, it inhibits the organification and the coupling, and therefore you release less T3 and T4. Now, over time, there's escape from the Wolff-Chaikoff effect. And what this means is that the sodium iodide symporter adapts to the environment of elevated iodine. Less iodine is then taken into the cell. These compounds are no longer formed, and then there's normal release of T3 and T4. Now, iodine-induced hypothyroidism happens when there is a failure to escape from the Wolff-Chaikoff effect, i.e. those compounds are still formed and there's still inhibition of the thyroperoxidase enzyme, and therefore there's less T4 and T3 being formed. And this can last for a variable amount of time, but it can be permanent, and it's more likely to be permanent in certain people. So those who may have thyroiditis, those who may have had Graves' disease that's previously been treated, people who have had thyroid surgery, or people who are using medications affecting the thyroid. Now, the fetus and the neonate can be particularly vulnerable to this iodine-induced hypothyroidism because their thyroids are immature. And people who have renal dysfunction can also be at risk if they receive contrast that contains iodine. There is a school of thought that excess iodine can also unmask the thyroglobulin epitope, and therefore increasing intrathyroidal T cells and increase the risk of autoimmunity. So autoimmunity may also contribute to this iodine-induced hypothyroidism. Now, iodine-induced hyperthyroidism occurs due to the Jod-Basedal phenomenon, in which there's a complete failure of the acute Wolff-Chaikoff effect. So instead of the thyroid cell battening down the hatches and reducing the amount of iodine it's taking in, there is no gatekeeping, so to speak. And so all of that iodine can then come into the cell. And this usually happens when you've got autonomous nodules which are exposed to excess iodine. And therefore, nodular thyroid disease is a major risk factor, but it can also occur in people with euthyroid Graves' disease, particularly after they've been treated with antithyroid medication. So there are not a lot of data, or certainly not as much data on iodine-induced thyroid dysfunction as there is on thyroid dysfunction associated with iodine deficiency in sub-Saharan Africa. But the case studies of the Sahrawi refugees in Algeria actually provides a window into trying to understand what happens and how this affects thyroid function. So these were from papers looking at 3-year follow-up of postpartum women who were in Algeria. You may remember my saying Algeria is one of those places where there is excess iodine exposure. And they looked at these women at baseline and at follow-up. And what they identified is that a third of the women, both at baseline and at follow-up, had some form of total thyroid dysfunction or antibody positivity. Much of this was hypothyroidism, but hyperthyroidism approached almost 10% in these instances. They also looked at the infants of these women who had excess iodine exposure, and again identified that nearly a quarter of them had some kind of total thyroid disturbance or elevated thyroglobulin. So highlighting that while it may not be as prevalent, exposure to excess iodine is also of health concern. So how do we manage overall iodine-related thyroid disorders? And I think the take-home message is that we need a public health solution to what is in effect a public health problem. So universal salt iodization with ongoing monitoring is essential. But it also means that not only must legislation be passed, but there has to be ongoing monitoring to ensure that the salt iodine content complies with legislation. And having done that, we also need to make sure that what's actually being used in households is iodized salt and not other forms of salt which do not have to comply with the legislations. And having done this, we also need to ensure that we keep up our surveillance to make sure that we assess on a regular basis what the iodine status is, not just of our traditional sentinel populations, our pregnant women and our school-aged children, but also our non-traditional sentinel populations. And I would just hasten to add there, following on Prof. Fasamande's comment, that we also need to make sure that we raise awareness, that people need to understand the importance of why we recommend iodized salt, what is the benefit of using iodized salt, and the impact that can have on their health and the health of their offspring. Thank you very much.
Thank you, Professor Alicia, for this wonderful presentation. I'm sure we've all had and we're jotting down our questions. So we'll take questions at the end, but we'll definitely move on to the next speaker quickly. That is Dr. Ifedayo Odeni, who will be talking to us on soft clinical hypothyroidism. But quickly, I will just take his short citation. Dr. Ifedayo Odeni is an associate professor of medicine in the Department of Medicine, College of Medicine, University of Lagos. He's also an honorary consultant physician and endocrinologist at Lagos University Teaching Hospital. He obtained his MBBS degree from the College of Medicine, University of Lagos, and a Doctor of Medicine, MD degree from the National Postgraduate Medical College of Nigeria. He's a fellow of the National Postgraduate Medical College of Nigeria in endocrinology and metabolism subspecialty, and a fellow of American College of Endocrinology. His research interests are in diabetes mellitus, adrenal gland, and thyroid gland. He has published articles in the national and international peer-reviewed journals. He has 45 publications in national and international journals. He had served on advisory board of many pharmaceutical companies. He has served as faculty at CMEs organized by pharmaceutical companies and other corporate bodies. He's also the current editor-in-chief of the Journal of Clinical Sciences. Dr. Odeni is happily married to Dr. Mrs. Olanike Odeni, a neurologist, and the unit blessed with 2 children. So I want to use this opportunity to welcome Dr. Ifedayo Odeni to take his lecture.
Thank you very much, Dr. Lokwade. I hope you can hear me clearly.
Yes, we can hear you, sir.
I'm trying to share my slide. it's coming up.
Yes, it's coming up.
Okay. Trying to get it into slideshow. Okay, I hope it's in slideshow.
Yes, it is.
All right. Good afternoon, the chairman, and I want to join the others in wishing you a happy birthday and more celebration to come. I think in the next 20 minutes or thereabout, I'm meant to talk to us about hypothyroidism, to treat or not to treat. Professor Wade has laid a very good foundation for my talk, and so some of the things I have on my slide, I won't need to go into deep explanation. Okay, so we are going to look at exploring the benefits and the risks of treating or not treating subclinical hypothyroidism. When we talk about subclinical hypothyroidism, we're talking about elevated TSH level with normal pretty full level, and the prevalence is quite high in general population. I'll come to that in the next slide. And it's quite important for us to look at subclinical hypothyroidism. Most of the time it is overlooked, and because most practitioners feel it doesn't have any strong health implication. But this is not the case. It's quite common as an endocrine disorder, and there are a lot of controversies surrounding whether we should treat or not treat. Looking at the prevalence of subclinical hypothyroidism in the general population, we have close to about 4 to 10% generally having hypothyroidism. Especially when we look at women, we have quite a lot of women who have subclinical hypothyroidism, followed by males. Women in the age above 60 years are noticed to have, hypothyroidism in up to about 20% of them. Patients with anti-TPO antibodies have up to about 18% of them with subclinical hypothyroidism. Unfortunately, most institutional patients who are not really, the focus on the thyroid gland is not on them, up to about 23% of them actually have subclinical hypothyroidism. The overview of the thyroid function and regulation has been well described by Professor Wadi, but I'll just briefly go over it for the benefit of some students who may be on this call and some other postgraduate students. Thyroid has a two lobe that is connected by the isthmus, and there is a follicular cell which actually produces the thyroid hormone. The parafollicular cell produces calcitonin and the hormone that is involved in calcium metabolism. Basically, the thyroid hormone, as we know, is the thyroxine, which is the T4, and the triiodothyronine, which is the T3. The synthesis starts with the uptake of iodine, and we've had this in the previous talk, and is absorbed from the bloodstream. The follicular cell produces thyroglobulin, which is a precursor to the production of the thyroid hormone. Iodine is now incorporated into the thyroglobulin to form a T3 and T4 through a process called iodination and coupling. The storage and release is in the colloid, and they are released into the bloodstream as needed. I need to mention at this stage that these hormones are actually released bound to thyroglobulin binding protein, and this actually has a protective effect on the body. You can imagine if the thyroid hormone are just released into the bloodstream without being bound, the effect will actually be overwhelming. The thyroid function is regulated by the hypothalamo-pituitary thyroid axis. And we all know the details of this. The thyrotropin stimulates the pituitary to produce TSH, which in turn acts on the thyroid gland to produce the release of T3 and T4. This mechanism is self-regulated by the negative feedback mechanism. So when the T3 and the T4 are very high, the TSH production is low. Same with the TRH production. Now, the role of the TSH is very critical in the regulation of the thyroid function. Just like we had in the last talk, it actually influences the size of the thyroid gland. It affects the hormone synthesis and the release of this hormone. The actions of the thyroid hormone on metabolism, growth and development, cardiovascular system. And this is one key area that we are going to probably focus on when we are talking about managing subclinical hypothyroidism, whether to treat or not to treat. It also has effect on the central nervous system, and there are other effects that we can see due to the thyroid hormone. They can have an impact on muscle function, the bone health, and gastrointestinal mobility. So what's the clinical relevance? Why are we talking about this? In the euthyroid state, we have a balance of T3 and T4, and they are within the normal range, and the TSH is also appropriately regulated. However, in the state where we have a low T3, a low T4, and a very high TSH, that is the hypothyroid state. And this is often caused by a thyroid gland that is not functioning very well. In hyperthyroidism, we have a very high level of T3 and T4 with a low TSH level. And this stands to reason from the regulation I discussed earlier. What are the possible pathogenetic causes of subclinical hypothyroidism? Iodine excess or deficiency will result in this, and I won't go into the detail of how this comes to be. That has been explained in the last talk. Autoimmune thyroiditis, aging. As we age, the thyroid function in producing T3 and T4 reduces, and as such, the TSH goes high, and that produces the picture of subclinical hypothyroidism in the aging population. Those who have had thyroid surgery, those who have had radioiodine therapy, and those on some medications like lithium, amiodarone, and interferon alpha can also present with subclinical hypothyroidism. And there are people who have genetic predisposition to developing subclinical hypothyroidism. Are these individuals symptomatic? Most time, majority don't have symptoms, or the symptoms may just be mild and non-specific. So we have our patients coming to us and they say they are fatigued, they are gaining much weight, they exercise and though they are still gaining weight. Some may have cold intolerance. However, some may not have anything, and so they may not have symptoms. So how do we diagnose people with subclinical hypothyroidism? TSH level between 4.5 to 10 micro-international unit per liter, a normal free T4 level is diagnostic of subclinical hypothyroidism. Sometimes we may need to repeat this test to be sure that the patient is not actually hypothyroid. The natural history of subclinical hypothyroidism is a progression to frank hypothyroidism. And this is a possible outcome if the subclinical hypothyroidism is not treated. So we can have a progression from SCH to overt hypothyroidism. There could also be a spontaneous normalization of TSH in those who have a subclinical hypothyroidism, and there could be a stable subclinical hypothyroidism. The TSH remain in that range of 4.5 to 10 micro international units, and the T3 and T4 remains normal, and it remains like this for a very long time. And there are also risk factors for progression to hypothyroidism. So if we look at this slide, we have towards the left of your screen, you have the euthyroid stage, where we have the TSH and the T4 are in the normal range. And this is what happened in normal individual. In subclinical hypothyroidism, the TSH is high, the T4 is still within the normal range. However, some individuals revert to euthyroid stage in up to about 60% of cases over 5 years, depending on the serum TSH concentration. Whereas we have some individuals, about 1 to 5% of cases can actually progress to overt hypothyroidism. Should we treat or should we not treat? If an individual has symptoms, then we need to treat, because there is a potential benefit in treating this individual. We also need to treat to prevent progression to overt hypothyroidism. When there are cardiovascular comorbidities, for example, we know that subclinical hypothyroidism has been linked to a very healthy cholesterol level. In this condition, we need to treat so that we can reduce the LDL cholesterol. It also has implications for blood pressure. So when we have cardiovascular morbidity in individuals with subclinical hypothyroidism, it's an indication for us to treat these individuals because of the benefits that we derive from them. There are other group of individuals that we need to treat because of the benefit that comes from the treatment. Pregnant women who have subclinical hypothyroidism also need to be treated. Patients with cardiovascular disease or risk factor, and young individual who has a likelihood of progression to hypothyroidism. Those who have neurocognitive function also need to be treated, and especially those in whom TSH level is above 10 and they have cognitive decline and they have a subclinical hypothyroidism, they will benefit from treatment. Those who have, treatment also reduces the risk of osteoporosis and fracture, especially in elderly. And for this reason, we also need to advance treatment to this group of individuals. The argument against treatment, it's also looking at, are we not going to be over-treating this individual? Why don't we just stay and watch them and see if there is tendency to progress, then we treat. So it depends on the side the physician is, but most especially what we should do as physician is to balance it, look at the patient before us and take a decision on individual basis. Now, we need to monitor TSH level if we are not treating this individual so that we are sure that the individual is not progressing to frank hypothyroidism. What supports this decision? There are guidelines. The American Thyroid Association guidelines actually says that treatment for subclinical hypothyroidism in patients who has TSH above 10, they should have treatment. Those with symptoms and those who have high cardiovascular risk or evidence of autoimmune disease should also be treated. And the association actually advised against routine treatment of subclinical hypothyroidism in TSH level below 10 unless these individuals are symptomatic. The same thing the European Thyroid Association put out, and is similar to what the American Thyroid Association has advised in terms of the guideline. Let's look at this patient with symptomatic high TSH. She presents with fatigue, weight gain, depression, dry skin, all of 6 months. She has difficulty with concentrating. Examination shows a dry skin, mild facial puffiness. Her TSH is 11.2 microinternational units. The T4 is at the low normal level, but she has an anti-TPO antibody that is very positive, and that signifies that she has autoimmune thyroiditis. LDL cholesterol is elevated as well as the total cholesterol. Their diagnosis here is subclinical hypothyroidism with the likelihood of progressing to overt hypothyroidism due to the Hashimoto thyroiditis that she has. And the management in her is recommends on 50 micrograms per day and adjusted based on TSH, lifestyle, and will follow up TSH reset in 6 to 8 weeks with also checking the lipid panel. So what influences that decision making? We look at the age, the symptom, because this patient is symptomatic. The TSH level is above 10. There are comorbidities, dyslipidemia is there. And of course, discussing with the patient preference also comes into play. Now, treating the patient is a shared decision that must be taken by the patient and the physician. And we need to weigh the benefit and the risk. So this guides us in how to approach patients with subclinical hypothyroidism. If the TSH is normal and the T4 is normal, we need to recheck and check the thyroid peroxidase antibody. If TSH normalizes and the thyroid peroxidase is negative, we monitor. If the thyroid peroxidase is positive, we recheck the thyroid function annually and make sure that the TSH is not rising. If the TSH remains elevated and the symptoms of hypothyroidism is absent, if the TSH is less than 10, we may not need to give any treatment, especially if it is between 4.5 and 7. However, if it's between 7 and 10, we may need to consider. Hello, can you still hear me?
Yeah, we can hear you.
Okay, so we may need to consider treatment, especially if this individual is below the age of 70 and there are cardiac and risk factors plus TPO antibody positive. If the TSH is above 10, it's recommended that treatment should be commenced if the age is less than 70. However, we have to be wary. If the patient is above 70, we'll probably give a 6 months treatment and follow up the patient to see if we can have a reversion to euthyroid state. So as I conclude, decision to treat is complex and individualized. We need to take into consideration whether the patient has symptoms, the age of the patient. We need to also look at other comorbidities, cardiac comorbidities, dyslipidemia, and other sources. The special group of patients, especially the pregnant women, also need to be considered when we are trying to decide whether to treat subclinical hypothyroidism or not. And it's also important to consider clinical evidence and patient factor so that at the end of the day, we are able to weigh the risk benefit and tend towards treating the patient in a way that it will benefit the patient without putting the patient at arm's length. Research is still needed, and these are still evolving. And by the time we have more data coming from researchers, we'll be able to evolve the guidelines and we are able to offer better treatment to our patients with subclinical hypothyroidism. These are the references. Thank you for your time.
Thank you, Dr. Ifedayodeni, for the beautiful presentation on subclinical hypothyroidism. And thank you so much. So we'll be taking questions at the end. Quickly, we'll be going to the next presentation. We're all aware that this webinar is also organized that's in conjunction with Thyroid Awareness and Support Initiative, and Dr. Ambassador Iroma of Forterville we'll be taking the next topic, which is on breaking the silence on thyroid disorders in Nigeria, the advocacy challenges, and the road ahead. Before she comes up, I'll just quickly take a short citation concerning that's a short citation on her. Ambassador Iroma Ofotebo is a global award-winning change maker, insurance expert, and certified social sector manager from Lagos Business School. She's a thyroid with net death experience, and she transformed her pain into purpose by founding the Thyroid Awareness and Support Initiative, that's TASI, the foremost patient-led non-profit for thyroid health in sub-Saharan Africa. Her resilience and impact has earned her the title Thyroid Queen among the thyroid community. Through TASI, she has led impactful awareness campaign, offers social support, and facilitate access to affordable, equitable, and quality healthcare and surgeries. Over 250 free and subsidized surgeries and counting for thyroid patients in collaboration with medical experts. She has built a thriving thyroid community of more than 500 members and impacted both rural and urban communities across Africa, across Nigeria. Iroma has represented African Patients Organization at major international forums as a speaker, including the Society of African Endocrinology Congress in Cote d'Ivoire in 2024 and the European Thyroid Association Congress in Italy in 2023. Is also a country member of Thyroid Federation International. She's married with 2 children, and she's passionate about healthy living, patients empowerment, and building inclusive health system across Africa. This evening, I want us to welcome Ambassador Iroma as she takes a topic on thyroid awareness in Nigeria. You're muted, ma. Kindly unmute, please.
Okay, good evening, doctors and everywhere. Standing on the existing protocol, I must say that I am very, very humbled and privileged to share the stage with the giants in endocrinology global. So join our daddy, we call him father, because he has been part of our organization since inception. That's Professor Made. A very happy birthday and happy World Thyroid Day to everyone. To all the doctors, thank you so much for the invite. I would love to share my screen. Please, can you see my screen?
Yes, we can see your screen, but not yet in slideshow.
Can you see my screen, my slides?
We can see your slides, but you can just put it in slideshow.
I'm trying to do that. But
there's a slideshow icon on top. Now, can move. It's either you go to the top, left-hand corner, the 4th icon. No, to the left, sorry, to your own right. Not.
do you see it now?
No, it's still not yet in slideshow. Can you go to your own left side? You see 4 buttons, 4 different icons there above the file home section. No, you're on the right side. Just go to the left side. So come up to the topmost, yes. No, so the other one. Yes, click on that. Okay, thank you. It's not in slideshow.
Okay, can you see it?
Yeah, we can see it.
Okay. I don't know. Okay, thank you very much. I hope you can see it very well now.
You're out of slideshow again. Just go back to slideshow. Yeah, we can see it now. Thank you.
All right. Okay, this is World Thyroid Day. I'm going to treat about breaking the silence on thyroid disorder in Nigeria, advocacy challenges, and the road ahead. Presented by Roma Fortube, President and founder of Thyroid Awareness and Support Initiative in collaboration with Endocrine and Metabolism Society of Nigeria. Thank you once again for the invite. Okay. The objective of this presentation highlights the side burden of thyroid infection, explore advocacy challenges and actionable solutions, raise awareness about thyroid disorders, advocate for improved healthcare responses and outcomes in Nigeria. The goal is to foster a supportive environment that promotes open discussion, timely diagnosis, and comprehensive care. Thyroid disorders are conditions that affect the thyroid gland responsible for regulating metabolism, heart rate, energy levels, and overall health. Thyroid gland, briefly, is a butterfly-shaped gland that is located at the base of the neck. Okay. Types of thyroid diseases that are found common in Nigeria are hypothyroidism, which has been discussed, hyperthyroidism, goiter, iodine deficiency, and even excess iodine, thyroid cancer, thyroid nodules. Yes, it has been noted that there is no precise data on the overall prevalence of thyroid disorder in Nigeria. Presently, thyroid disease is estimated to be underreported due to poor awareness, misdiagnosis, and undiagnosed cases. The available data varies from one geographical location to another. But one study I found that says that in southern Nigeria, hyperthyroidism is rated the highest, followed by goiter and hypothyroidism. Some reported as goiter as more prevalent. But from our own organization in TASI, record says that hyperthyroidism caused by Graves' disease are significantly more prevalent. Okay, challenges in advocacy, both in rural and urban areas. The dearth of awareness, basically caused by misdiagnosis. Thyroid disorders are often mistaken because their symptoms mimic other health conditions. This results to treating symptoms and not the underlying causes. Poor awareness on the general public and healthcare officials, misconceptions, permit me to say that most of the times when patients go to the hospital, they don't really get, because of the symptoms, they don't really get the right diagnosis, therefore treating their ailments without even sending them to the lab. Most of the times, because of the similar symptoms that other health conditions can present. So they might tell them that it's hormonal changes, stress, menopause, or maybe cardiovascular issues, which may be treated, at the just on the surface without getting to the underlying causes. Then another challenge we encounter is the culture, the belief system. We are all in Africa, and we know how the kind of cultural and societal beliefs attached to certain illnesses, linking goiter to causes, witchcrafts, and spiritual attacks, especially those with the family history. I've encountered a lot of patients who come to me and say that somebody is bewitching them, their mother had it, their father, their auntie had it, there is one person that is bewitching all of them. But proper awareness will help to inform all those people and empower them with enough knowledge to know that thyroid disease is a medical problem that could be hereditary as well. This results to consulting herbs merchants, all these people selling herbs, and even with all the money they spend, they cause more complications and more harms to themselves. Even those religious leaders, some of them, fake ones, they're not even helping matters, because some of them will, when they go to consult them or to pray for them, they will tell them this is not a medical issue. This is a spiritual issue. They collect money from them and even threaten them that if they do surgery or they go for medical solution, that they will die. So those are the challenges. And then healthcare access. Okay, this is a very important, very big challenge because of lack of, we don't have, there's overwhelming cases of thyroid disorders. And that, as a result, there is a limited access to endocrinologists or thyroidologists, and also diagnostic tools, especially in the rural areas. Talking in the capacity of a thyroid disease survivor, an advocate, and I must tell you that those are the challenges I encountered during my own time, which prolonged my case to 6 years. I couldn't access the proper specialists and also get the right place to do my labs. I can remember that time, the first place I was sent to was Lagos State Teaching Hospital. As at that time, they have like 5 labs. None of them was doing, conducting any thyroid function test. But I learned that now they've started it. So, but it's still like that, especially in the rural areas. Assessing all this, they are very, very difficult and far-fetched at times. Then paucity of funds. Advocacy of thyroid disease is very, very, very strenuous and challenging in the area of funds. There is a serious financial constraint because driving that advocacy, because government is not paying attention and it has not gained that kind of popularity that makes people to join and sponsor. It's a very serious challenge to us. Reaching underserved, low literacy communities. One of our core values are inclusion, equity, diversity, and technological concepts, and equity, diversity, and inclusion. So in that case, we always consider those people in the underserved communities, how to reach them, is a very big challenge as I'm talking to you, because they are even the people that need all this awareness and sensitization more than people that can access some technological items. Then policy support, lack of thyroid-specific national health policies, including thyroid disease in the national health policies, is still far-fetched, is still not considered. Government has not given thyroid disorders on due attention, significant attention. I don't know, maybe because they considered it the second most common endocrine disease. Then lack of national data. Lack of national data is a challenge in approaching the treatment of thyroid disorders or even policy inclusion. Okay, current advocacy efforts. My organization that I represent, Thyroid Awareness and Support Initiative and Thyroid Care Association of Nigeria, doctors and other medical experts and primary healthcare board, especially in Lagos State, we have been pushing and driving this advocacy tirelessly. We do it in collaboration. We couldn't have achieved all we've been able to achieve without collaboration. Thyroid Care Association was founded by Dr. Afolabi of University College Ibadan. We have organized a couple of programs with him, including a public lecture. Professor Fason Made is also part of us, advocating for a better improving the lives of thyroid patients and awareness, which he has also rightly mentioned in this forum. Then some of the initiatives that we've carried out, community outreaches, about more than 20 communities have benefited from our outreaches, screening, free surgeries, subsidized surgeries. We produced like more than 250 free and subsidized surgery beneficiaries. Then communities, more than 20 also. We do this by through collaborations. Then World Thyroid Day and International Thyroid Awareness Week campaigns, we go out sensitizing people, sharing awareness materials and one-on-one sensitization. Then media awareness, we leverage radio, TV, social media, print, online. TASI, my organization, has a very strong footprint on social media. And it's a very, very, very important channel for us to disseminate information. Then grassroots sensitization, we go to the rural areas to sensitize them in collaboration with local, that is traditional leaders. All these things are intended to end all these societal stigma, to allow people, to encourage them to come out and seek medical treatment without any fear or shame. Then community engagement. Any community we go to, we try to engage them to participate in the issues concerning them. And thereby we get their attention. These are some of our activities. We have a adopt a patient scheme where we encourage individuals, charitable individuals, churches, corporate organizations, philanthropists, humanitarian agencies to adopt patients and cater for their medical needs from start to finish. Then these are some of our awareness outings in the community, screening going on here. Then these are one of our media outreach with Professor Fason Made. These are the free beneficiaries of free surgeries on my right. Then this is one of our road sessions. This was in about 3 years ago or 4 years ago. We do it every year on World Thyroid Day, but we couldn't do this year. This is television interview awareness. These are the media. This is community sensitization. Then one of our beneficiaries too. All we are committed to is to put smiles in the faces of people. Then strategies to overcome challenges. Number one is capacity building. There is need to increase training and awareness for healthcare professionals to keep learning and unlearning on how to handle thyroid patients. Then local healthcare workers that we most of the times engage at the grassroots levels. Then thyroid champions also need to know, to learn, which some of them are on this platform now. And the public, general public, via diverse means and mediums on thyroid health and disorders. There is also need to promote community-based programs, grassroots programs, then raise support groups, which we have a community of about 500 patients and outreaches, then advocate for policy changes and government support at the national and local levels. Then way forward, at this level, I want to appreciate all our doctors seated there and those absent that are not here. I understand what you people are going through. I experience it too. Like I said before, there is an overwhelming rate of thyroid disorder. As the awareness is going on, people are coming up, people are being diagnosed, and the rate of thyroid disease is going up. That's why we need a very precise data on it. So, but however, we appeal to our specialists to also support our patients with emotional, psychological, and even physical support, as we give medical support, because empathy is very, very therapeutic and is very, very important. Judging from my own angle, I was being treated by a doctor, a very big one, but I did not get, I wasn't improving. It wasn't only, he recommended my own, I had hyperthyroidism. But the thing is, when I get to the doctor and ask the doctor, what is wrong with me? Explain to me. I needed to hear something. I needed him to say, calm down, this is not a death sentence. Because I thought that that disease was gonna kill me. He didn't give me what I wanted. At a stage, I dropped my drugs. I was frustrated. And that is the average story. And this is the story of an average thyroid patient. I understand that doctors are very, very overwhelmed, but please, we appeal for more empathy on the part of the patients. What the doctor was doing that time was to give me one big book and tell me to go inside to go and read. With all the anxiety, the panic attacks and everything, for concentration, there was no way I could have concentrated. Rather, I got more frustrated. So those are the things that will help our patients also to heal psychologically, emotionally, and mentally. Then, as we're doing now, this is a wonderful collaboration, forming partnerships like this with stakeholders, media specialists, media, government at all levels, CSOs, healthcare providers, diagnostic centers, and other ones I listed here, will help to develop and implement a comprehensive national health strategy. And it will help to scale up outreach, education, and support programs. It will also help in lobbying for thyroid routine thyroid screening in maternal and newborn screening for early detection of congenital thyroid disorder. This time around, diabetes is very, very, very popular. It's a popular one. International body are pouring their money into it. We also want to use this opportunity to appeal to all stakeholders involved to join us in driving this awareness and advocacy to be able to attract funding to handle thyroid disorders in Nigeria. Make it popular. Let us join our voice. Then improved research. We need more and more research. Then for monitoring, establish systems for monitoring, evaluation, track awareness growth, data collection, and continuous improvement. Then another way forward is policy advocacy, advocating for stronger health policies and government support. Push for inclusion of thyroid care in primary healthcare packages, like other popular health conditions, because every health condition is a condition, is a sickness. Everybody has right to be healthy. Then innovations and opportunities, like the theme of this World Thyroid Day 2025 says, thyroid disease and AI. Technology is very, very critical in driving thyroid awareness, exploring different treatment opportunities and diagnosis. The use of SMS alerts, WhatsApp groups, and mobile health apps will help to improve patient outcomes. Social media for awareness campaigns, digital diagnostic, telemedicine, and digital medical equipment enhance awareness and improve better treatment outcomes. It is partnering with international health organization for support and funding, and leveraging data collection tools for better monitoring and reporting. References. Oh, this is not really. Okay. Then in conclusion, is a call to action. Thyroid disorders are silent epidemic with major health impacts in Nigeria and Africa at large. Yet they have not been given significant attention like other popular health conditions. The crucial need for increased awareness, support, and government actions are critical. Increased awareness, access to healthcare, early detection, and management of thyroid disorders can prevent complications and improve the quality of life for the affected individuals. Now, as we're gathered here with all the stakeholders in the medical space, in the industries, corporate organizations, government agencies, it is our collective responsibilities. Responsibility to join our voices, our expertise, action, and resources to break the silence. We need to together advocate, educate, and support. Together, we win the battle against thyroid disorders in Nigeria. We are open. Thank you very much for listening. Thank you for your time. We are open to collaborations and partnerships. You can contact us on the listed our website, www.tasinigeria.org, or you can send us an email, tasinigeria@gmail.com. Then you can contact us also on 08033348888. Thank you very much.
Thank you, Ambassador Roma, for the beautiful presentation. I'm sure we've listened to the three erudite speakers this evening, and I want to hand over to the chairman to moderate this session on question and answer. And we also want to use this opportunity to welcome all our guests who have listened to all this presentation this evening. So over to you, Professor Fasumade-san.
Thank you very, very much, Dr. Olopade, for being a good anchor So I think what is left now is for us to take questions, answers, comments from the general audience. And we've had 3 erudite speakers. We've had 2 professionals, and then we've also had a patient advocate all speak on different aspects of thyroid diseases. So it's just left for people who have comments. And what you can do is you could put the comments on the comment section, or you could raise your electronic hand, and then the host will recognize you and allow you to speak. But please, we hope that when you speak, try and make it brief so that we can have as many people as possible contributing. I think already on the platform, there are a few questions, and I'll take the first one. The first one is, good afternoon, everyone. That is from Eunice TK. Says, recently a group made a presentation and concluded that the treatment of SCH, I'm assuming it means subclinical hypothyroidism, is not to be treated in pregnancy or in those wishing to be pregnant, as it offers no benefits. Says, I would like Dr. Odeni to comment on this. So I think that's the first question. So, Professor Odeni, you can have a swing at this one. Talking about subclinical, I'm not sure that it's hyper or hypothyroidism, but it's just that SCH.
Okay,
So,
I think it's a subclinical hypothyroidism. Okay, thank you for that question. Now, there are benefits of treating pregnant women who have subclinical hypothyroidism. Now, we all should know that the thyroid hormones are very critical for fetal brain development, especially during the first trimester, when the fetus is dependent on the maternal thyroid hormone. This is a very critical point. If the thyroid hormone is very low at this point, then the fetal brain development will be affected. So subclinical hypothyroidism in pregnancy has been associated with increased risk of miscarriage, preterm birth, and impaired neurodevelopment in children. So these are the consequences of not treating subclinical hypothyroidism. Now, in the guideline that I displayed during my talk, the American Thyroid Association actually recommends treating pregnant women or women trying to conceive when the TSH is above 2.5 micro-international units per liter to prevent complication and optimize the pregnancy outcome. So I don't know where the group got their data from, but the benefit of treating a pregnant woman or a woman who is desirous of getting pregnant, whose TSH falls in the range of subclinical hypothyroidism, the benefit of treating far outweigh not treating the patient. I hope I have answered Eunice's question.
thank you very much, Dr. Denny, because we all know that even the gynecologist, any woman who is going for IVF treatment, if the TSH level is greater than 2.5, they are likely to send the person to the endocrinologist to manage and to treat before they proceed with the IVF. And that is because of the morbidity and the mortality associated with hypothyroidism. You can have fetal wastage, you can have congenital hypothyroidism and cretinism, and then also obstetric complications. So all of these are common in people that have TSHs that are high. So thank you, Dr. Denny, for giving that information. The next question here is that when do you
Professor Alicia is listening.
Okay.
I was wondering if I may weigh in on that question as well.
Yeah, go on,
Right,
Alicia.
so I think the data are conflicting. So there's some studies which obviously show a benefit of treating these patients with thyroid hormone. There are other studies which show that there is no benefit. But what I would say is that what you're considering in this instance is a low risk intervention. Right? You're talking about putting somebody on thyroid hormone, which if it's dosed correctly is a very low risk intervention for a very small period of time with potential benefit. So I think when you weigh the potential risk-benefit ratio of that, then I think there's certainly an argument to be made for treating these women.
Thank you very much, Alicia, for that, because once you get the dosage right, you don't really have a high risk from treating these women. So thank you for enlightening further on that. So is there any other question?
Professor Fasumadi, you're muted, sir.
Okay, sorry. Yes, yes. I said there are two questions in the comment section. One of them is, when do you treat subclinical hyperthyroidism? And with the high prevalence of Graves' disease, how accessible is radioiodine therapy in Nigeria? Again, I think this question might be for Dr. Denny. Treatment of subclinical hyperthyroidism. Says, when do you treat subclinical hyperthyroidism and how readily available is radioiodine treatment?
So with subclinical hyperthyroidism, just like it sounds, it's subclinical, but then we also need to look at the patient as a whole and look at if there are other comorbidities in this patient. Generally, we don't go out treating patients with subclinical hyperthyroidism. We monitor them periodically to be sure that they are not going to progress into frank hyperthyroidism. In terms of Graves' disease and radioiodine therapy, yes, we have centers in Nigeria that offers radioiodine therapy. We have one in, I think one or two in Abuja. I think the National Hospital offers radioiodine therapy for this patient, and there are some private hospitals that also offers radioiodine therapy. Hospitals like hospital offers radioiodine therapy, and I think there are others. I may not have the whole list to give at this presentation.
Thank you very much, Dr. Denny, for that. It's not so readily available in Nigeria, but there are a few places like UCH and then the National Hospital Abuja. I think Evercare in Lekki is about to start or they've started. It's not readily or commonly available. Yes. Another question on the comment section is, good day,
Sorry,
everyone.
Prof, may I weigh in on that one as well?
Yes, you can.
Wonderful, thank you. So I think that, in addition to what Dr. Odieni mentioned, I think there are also a few other things you can take into consideration if you have a patient with subclinical hyperthyroidism. So one, he mentioned comorbidity. So particularly if you have an older patient, a patient who's older than say 65 or 70, who's at risk of cardiovascular disease, who's at risk of cardiac dysrhythmias because of their subclinical hyperthyroidism, then you may want to treat that person. Additionally, if somebody has got a persistently completely suppressed or undetectable TSH, so as with subclinical hypothyroidism, you're going to have a range of low TSH. You're going to have TSH that's below the lower limit of normal. Then you're going to have TSH that's completely undetectable. So there are some authorities who would recommend people who have a persistently completely undetectable TSH that would also recommend treating those patients. So those are some of the factors you may also wish to take into consideration.
Thank you very much, Alicia. Thank you for that. Let's see whether there are more questions here. Someone is asking, what causes breast pain from a thyroid patient? Alicia, you want to take that too? Patient with breast pain.
So happy to do so. So I think it's an interesting question, and I'm not sure necessarily that breast pain is a typical feature of thyroid dysfunction. I think you want to approach this patient like anybody else with breast pain. You try to understand, is this cyclical? Is it non-cyclical? Is it unilateral? Is it bilateral? Are there any structural issues that are associated that may give you concern? So one thing that could possibly be, if you have a patient who's significantly hypothyroid, and then therefore that patient may be edematous or retaining fluid for some reason, then some of that fluid retention may be associated, just be in the breast, and therefore that causing the breast pain. But I don't think there's any particular syndrome of mastalgia or mastodynia that's specific to patients who have thyroid disease.
Yeah, thank you for that, Alicia. Although some people who have very high TSH levels, they might have galactorrhea, but usually they don't typically have breast pain. So once you have a patient with breast pain, please send them to have either a breast surgeon or somebody who is skilled in that area to do imaging and to examine them properly. So let us see which other question here. Somebody has put another question. Some years ago, this is a long one. I was diagnosed with thyroid. A long time ago, I was diagnosed with thyroid disease. It is neither hyperthyroidism nor hypothyroidism. I've been carrying out the thyroid function test, which is always within limits. My doctor is not giving me any treatment, but advises me to carry out the TSH test every 6 months. Do I need to worry? Because my temperature is always fluctuating. 1 minute I am cold, and the next I am hot. So this one is open for either Alicia or if any of you can take this one. I think this is from a patient with thyroid disease.
I'm happy to jump in. So I think it's always a little difficult, in the absence of all the information, to comment on these things. And it's challenging. I think maybe what it would be worthwhile is actually having a conversation with your doctor and saying, listen, can you tell me what's going on or tell me what you're thinking is happening? Now, if this person has got thyroid, if you have thyroid function tests which have been normal, then you don't have thyroid dysfunction by definition. So thyroid dysfunction is a biochemical diagnosis. And obviously, one of the challenges, as I think all of my clinical colleagues on the webinar will agree, is the symptoms of thyroid dysfunction can be very non-specific. And so you can, which means they can be due to many other things. So for that reason, we very much depend on your thyroid function tests as the arbiter as whether or not your symptoms are due to thyroid dysfunction or if they're not due to thyroid dysfunction. So in this instance, if you've got completely normal thyroid function tests, then I think it's worth a discussion with your doctor about, well, what else could possibly be causing your symptoms? Because I don't think we can blame your thyroid if your thyroid function tests have been normal. If you have had a diagnosis of thyroid disease sometime in the past, there is a condition called thyroiditis, or we call lots of things thyroiditis, so it can be confusing. You could have had what we call a silent thyroiditis, which, can get better by itself and in fact usually often does, and sometimes recurs, but sometimes doesn't. So that is one instance when you could have had a thyroid disease, which is now resolved without any specific therapy. But if your thyroid function tests are now normal, then I think, it's worth a discussion with your doctor about, well, what else could potentially be causing these symptoms?
And if I may add here, I agree with Alicia. Now the other thing is the person asking this question added that one time she's cold, one time she's hot. We may not put this beyond menopause, though we don't know your age, but it could just be some menopausal symptoms that we are facing here if your thyroid function is normal. And so you still need to discuss with your doctor to get a full explanation of what is happening in your body.
Thank you very much, Alicia and Ifeda, for those answers. So please consult your doctor, as the webinar cannot replace a full examination and consultation since we don't have all the information. Another person, Chioma Chukwuka, is asking that is there a food that we can use? He says, my question is, how can we avoid this thyroid disease? Is there a meal or food to eat or to avoid? And if after the surgery, is it possible for it to recur again? If yes, why? And if no, how do you manage it? How do you manage it? And the person says, thank you. So, yes, I think this is more from Alicia's lecture.
So I'm happy to take that one as well. So like a lot of things, there's some genetic determinant in how your genetics interact with your environment. So in terms of what we can do to prevent thyroid disease, I think the main thing we can do is make sure that on a population basis, we're iodine sufficient. As I said, provided you in a country with iodized that has iodized salt widely available, that's used, you use it in cooking, etc., you're unlikely to be iodine deficient, with the provisos that I made. So let's say, for example, you are, you've got access to iodized salt, you make a concerted effort to use it in your cooking, etc., you're unlikely to be iodine deficient. Now, beyond that, I don't usually advocate making any particular dietary changes to prevent thyroid disease. There are instances, for example, where foods such as kelp and supplements, which are very high in iodine, can potentially precipitate thyroid dysfunction in the ways that I discussed. But I mean, then your intake of those types of foods really has to be very, very high. So I don't really advocate on usually making any particular modifications to your diet. With regard to the goitrogens, which I mentioned, remember, they only cause thyroid disorders in the setting of iodine deficiency. So if you're getting enough iodine, then that's not really a concern. And your second question, so essentially, I think, as I always tell my patients, the rules are for eating a healthy diet are the rules for eating a healthy diet, and they extend across most conditions. Now, if after surgery, is it possible for it to recur? So I think that really depends on what the motivation for the surgery is. So the instances in which we will do surgery for thyroid disorders will be if someone has got hyperthyroidism. So either if they have Graves' disease or if they have autonomous or toxic thyroid nodule, or if somebody has a non-functional thyroid nodule, but a very large goiter, or if somebody has got thyroid cancer. So those are really the three reasons we would do surgery for somebody with thyroid disease. Now, if somebody has got autonomous thyroid disease, so say Graves' disease, for example, depending on the extent of the surgery, if a total thyroidectomy is done, then no, the Graves' disease will not occur because there's no thyroid left for the Graves' disease to occur in again. So that's not usually an issue. If it's done, say, for example, someone has a partial thyroidectomy or it's a subtotal thyroidectomy, so there's still some thyroid tissue left, then it's possible that whatever residual thyroid tissue is there can, become sufficiently hyperthyroid to cause symptoms of Graves' disease again. In somebody who's got a toxic nodule, so i.e. you've got a thyroid nodule that's producing too much thyroid hormone, usually the surgical approach will be just to take out that part of the thyroid that's affected. So they won't take out the whole thyroid, but just the part of the thyroid that's affected. So once there's thyroid tissue left, then yes, there is a possibility in that case that another nodule can occur in that part of the thyroid tissue that's left and can start, becoming hyperfunctioning again. So that's possible, and that's also why it can happen. And if it does happen, you treat it the same way you treat, someone if they were presenting for the first time, which is you have the options of surgery, you have the options of medication, and then you have the options of radioactive iodine where it's available. And then if you're doing surgery for a goiter, so just an enlarged thyroid gland that's not functional, once it's taken out, it shouldn't recur because there is no thyroid left. And then the last indication for surgery I mentioned is thyroid cancer. So yes, there is a possibility in people who have thyroid cancer, depending on the extent of the thyroid cancer and the pathology and how aggressive it is, for thyroid cancer to recur. So if someone who's got, has half their thyroid taken out for thyroid cancer, there's also always a possibility of the cancer recurring in the other half of the thyroid. And in anybody who's had either a part of their thyroid or their whole thyroid taken out, there's always a chance of recurrence of thyroid cancer in lymph nodes or in other part of the body, as there is with any other type of cancer. So for that reason, with patients who have thyroid cancer, we always have to keep up active surveillance for, particularly depending on the type of thyroid cancer, but lifelong surveillance to monitor for occurrence.
Thank you. Thank you very much. Let me see. Are there still comments? We are running out of time, so we might not be able to take all the questions. Let me just see which one is very, very vital.
Sorry, Mr. Chairman, my hand has been up. Is it possible that I can?
Yes, okay, Professor Loko, you can talk. Sorry, I didn't see your hand. Forgive me. Professor Andrew Loko, yes, please go ahead.
Yeah, thank you so much for all the presenters. Wonderful lectures. I have a couple of questions, but I'll be very brief. Alicia, you agree with me from your talk that there are no data in some 20 African countries on the status of iodine in our population. This raises a point for more work, if you agree with me. There will be a need for more research in this respect. And so I listened carefully when you talked about determination of population iodine status, and you mentioned the different methods ranging from urinary iodine concentration, thyroglobulin concentration, neonatal thyroid stimulating hormone, and thyroid volume. In your opinion, if we want to undertake a population-based study now in our own context in Africa, which of this method would you recommend that will be amenable to use that will give a fairly representative result? I don't know if I should ask all the questions and then the responses. The second question, very quickly, is with the talk on subclinical hypothyroidism. Professor Odeni, I really liked your talk. The algorithm was very helpful. I know it's an area of controversy when you talk about to treat or not to treat subclinical hypothyroidism. The guidelines you gave were some authorities, and they spoke mainly to treat once TSH is above 10. What would be your recommendation if TSH is between 5 to 9? I'm talking in the context of Nigeria and then in the context of EMSON. Don't you think we should have a statement from EMSON that this is our position statement, even though we will argue that we need to back it up with available data from local studies? And finally, the talk from the thyroid queen was excellent. I was fascinated by the fact that you do a lot of thyroid surgeries. I was wondering who pays and how you generate the funds for that. And of course, like you rightly captured it, I can't say it any better. The need for collaboration with EMSON is really very important. And I think if we join forces, we can get the Federal Ministry of Health to listen to us. In the coming months at EMSON, we plan to roll out guidelines on thyroid diseases. Thank you so very much, everybody.
Okay, so I think your questions were directed towards Alicia, so she will take it.
Okay, so I'll take the first two. So yes, there is definitely a paucity of data on iodine status in sub-Saharan Africa, certainly up-to-date data. I think that extends more broadly to thyroidology in general. And, I fully endorse the comments which our last speaker made in that we just don't know what's going on in the majority of sub-Saharan Africa when it comes to thyroid disease. We have very little data on thyroid dysfunction, thyroid cancer. You name it, we have very little data on it. So I think there's definitely a need for more data there. Now, in terms of the best biomarker, I think it's going to determine your question. I do think assessing things like thyroid volume are difficult because really to do those accurately, you need ultrasound access. I think neonatal TSH is actually a little challenging as well. I think probably our best bets would be looking at urinary iodine concentration. There's a lot of work showing that doing spot urinary iodine concentration is just as good as doing a 24-hour urine, or also looking at thyroglobulin. So I think the benefit of that is one can then look at short-term versus longer-term iodine adequacy, and then the dried blood spots are actually quite easy to take and maybe easier to take and store and handle and subject to less pre-analytic variability than something like the urine iodine concentration.
Okay, thank you. Professor, anything you have to add there, or Dr. Lopade? Okay, so Professor Luko directed the question at me about so what do I think looking at our population. So just like he has actually answered that question, I cannot postulate anything without data. Okay, so we can only lean on the guideline that we have for now and use that to at least manage our population as best as we can. So TSH still below 10, and with the slide I give a guideline on how to go about it when we look at the age below 70, above 70, and that we may actually adapt that and individually look at our patients and offer them the best treatment. So I won't be able to categorically say, oh, at this level of TSH, this is what we do for our own population, because sincerely, I don't have any data to support that. Okay, thank you, Saleni, except one just wants to put level of evidence as E, which is expert opinion, which doesn't carry too much water. So it's a bit hard, and that is a great area. And I think Professor Udoko is saying that we need to do some work in this area. Either have a small committee to look at either data from neighboring countries or try to generate our own data to see the outcomes of patients that have TSH between 5 and 9, comparing them with outcomes or health status of those with TSH levels below 5 and then those above 10. So those are the things that we could do, or we can lean on similar populations if there are any adjacent to us and see whether those can be adopted by us. So I think we are far beyond the time. There are about still 4 questions, but these questions are specific questions which are not too sure to be right for us to be taking. There is one about a lady with palpitations. We don't know what your thyroid function is all about. There is another person who is asking whether it is right to go for surgery. Unfortunately, we might not be able to answer that because it depends on so many factors. It depends on the size of your thyroid, depends on what you've done, the nature of the thyroid, the FNAC results. Another person is talking about applications again, and that one too still depends upon your thyroid function test. If you have specific questions relating to your own case, it's always better to see your physician because they will have all your details and all your records, and with that, they will be able to give you appropriate advice. It's not too neat giving such counsel online here when we don't have all of your details and we've not examined you. So I think with this, it's been a wonderful day, and I will be handing over to Dr. B. Adeshina. I think he's the next person that will be talking. Since I will not be talking again after that, I want to thank so much Professor Alicia, and I want to thank Professor Denny, and also thank uh, uh, Mrs. Opotude. So, D, over to you.
I'd like to thank every one of us for attending this World Thyroid celebration today. I'd like to especially thank Professor Alicia, thank Professor Odeni, thank Ambassador Ofortube for their presentations today. We have been bettered by listening to them. And all those of us who have listened to them, all those of us who have asked questions, I thank us all. That has made this presentation a very useful one. It's our prayer and hope that come next year again on World Thyroid Day, we will have something that is very impactful for those living with one form of thyroid or another, and those of us who also care for them. So on behalf of the Endocrine and Metabolic Society of Nigeria, I want to thank us all for attending. Thank you. Thank you, Dr. Adishino. Thank you, everyone, for attending this webinar. I want to appreciate every one of us. Let us have a lovely evening. Thank you all.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you, everybody.
Thank you.
Thank
Bye-bye.
you. God bless you for the awareness.
Thank you.
Thank you so much.
Thank you.
Thank you.
Bye. Thank you.
Bye.
Thank you, Dr. Lokmade.
Oh, thank you for coming.
Thank you
Thank
very
you.
much.
Oh,
That
thank
was a
you.
nice outing.
Okay,
Thank you
yes,
so
ma'am.
much.
No problem. Yes.